for drug interactions with Namenda. Any drug that interferes with the kidneys being able to get rid of Namenda or memantine should be avoided. And other drugs that we have seen before that can cause side and adverse effects like quinidine and dextromethorphan should be avoided. They don't mix well with an NMDA blocker. Some things that we as nurses need to know and need to teach the patient and their family. You want to monitor the patient's neurologic function before they ever start on it, and then a baseline serum creatinine and BUN, which assesses kidney function, and then some liver function tests. And then periodically these tests would need to be repeated while the person is on an NMDA blocker. You want to notify the healthcare provider of any changes from the baseline. The patient should be weighed weekly because of the risk of losing weight that you see with Alzheimer's and with the medications that can sometimes cut the appetite. If you are giving Namenda in oral form, you don't want to mix with other liquids. You want to give it along with or by itself with an eyedropper. If you have extended release Namenda, you can open it and put it in applesauce if your patient will take anything by mouth. Sometimes you get to where the patient won't eat anything else with a spoon, but they will drink things. You want to give the full dose of Namenda, and many times Namenda and Aricept or the other cholinesterase inhibitors are given together to enhance their action. Notice that's in red. Patient and family teaching is on page 169, and there's just a few bullet points. And on page 168, you'll see a few nursing considerations also that we should learn. So next thing we're going to talk about is seizure disorders, and this is quite a long section out of this chapter. When we think of seizures, we tend to think of the full-blown tonic-clonic seizure, used to be called grand mal seizures, where the patient usually just falls right to the ground and starts having rhythmic muscular contractions that seize up and relax. And that's often what we think of when we hear seizures, but that is not always the case. There are quite a few different kinds of seizures. Now, in the textbook, the chapter begins by saying drugs for epilepsy. Now, epilepsy can cause seizures, but not all seizures are caused by epilepsy. Sometimes you will get seizures from drug use, alcohol withdrawal, fever, especially in small children. Lots of different things could lead to seizures. It's not just epilepsy, but this book kind of calls itself, or this section of the chapter kind of calls itself drugs for epilepsy. But remember, we could have seizures for other reasons. And one of the main causes of seizures is a failure to take meds in somebody who's already been diagnosed with seizures. If you look on page 170, we see box 9.5, and it gives a classification of the major seizure types that you might see. It's not just the grand mal. You can have several other kinds too, including status epilepticus, which is just a series of tonic-clonic seizures that just keep repeating themselves, and that's life-threatening. There are also some genetic syndromes that can cause seizures. Dravet or Dravet syndrome is one. There are others, and sometimes they don't show up until a child has gotten to be a few months old. Some can show up in childhood, some show up for other reasons. Some are just idiopathic. Nobody really knows what causes them. Now, for years, there have been certain kinds of drugs to treat seizures. They're known as traditional drugs. The most important action a nurse can perform when working with seizure patients is to always ask about other meds that the patient has taken or is taking. Anti-seizure drugs, or AEDs, anti-epileptic drugs, have varying degrees of success, and you want to always assess what the patient has and is taking. So the categories of traditional drugs that we're going to see is a category called the hydantoins or the phenytoins, carbamazepine, ethosuximide, the barbiturates, primarily phenobarbital, and then a drug known as valproic acid or Depakote. When it comes to the hydantoins, that's a pretty common drug that's been used throughout history. It's been around a long time. The trade name is Dilantin. It works on the motor cortex, and it stops those abnormal electrical impulses that can lead to seizures by controlling sodium ion movement across the motor cortex. So by increasing and decreasing the amount of sodium, they can cut down on the risk of abnormal electrical impulses that could then cause a seizure. The hydantoins can be used to prevent grand mal or clonic-tonic seizures, psychomotor seizures, status epilepticus, and sometimes you can use it to treat migraines and trigeminal neuralgia. Remember, I talked about trigeminal neuralgia, which is just horrendous pain, almost like a migraine in the face, by irritation of the trigeminal nerve. Now, the biggest known side effect with the phenytoins is gingival hyperplasia. This is a very common question asked in NCLEX and ATI. Overgrowth of the gums can be caused by Dilantin. Also, abdominal discomfort. It's not very comfortable to take sometimes. If a woman who is pregnant has been taking Dilantin, it can cause severe birth defects. Over a period of time, a child who starts on Dilantin early can show a coarsening of the facial features. You can see gynecomastia or breast enlargement in men and some abnormalities with the blood. The hydantoins, such as Dilantin, are extremely irritating to the tissues. Really, really painful. So you don't want to give this drug IM. You would take it in PO form to prevent to prevent seizures. Here we see a picture of gingival hyperplasia. You can see the gums are pretty severely overgrown. They're trying to take over the teeth. So somebody who's taking Dilantin regularly is going to need to have regular dentist visits so they can check on the progress of the gums and sort of scale things back.